Finally, we come to the pathology of dental caries. The word pathology means the changes or the deviation than the normal structure that we know. So we studied the normal structure in the oral histology last year, and any deviation is a pathology. When we talk about pathology, we see how the disease takes place, the sequence of events, and how can we study these changes, the means by which we can see or study these changes. Usually in the tooth, we talk or we divide the pathology into enamel, dentine, and cementum because each of these structures differs in its composition, and so its reaction to dental caries differs as well, or the spreading or the speed by which dental caries takes place in these structures differs from one to another. Usually we start with the enamel because enamel should or is always the first thing attacked with the caries, and this is because most of the crowns in the oral cavity are usually covered by enamel. Sometimes, and enamel is considered to be the hardest tissue in the body, and it should be protecting the teeth. It should be there to protect the teeth against the acids and the bacteria and the food in the oral cavity or the oral environment. Some other times, other sites like the cementum or the dentine can be affected. Dentine can be affected if the enamel is broken or chipped away. Cementum can be affected or can be the first site for caries if there is gingival recession or periodontal disease, and so the root is exposed. Usually enamel should be so hard and protects the teeth unless this patient has bad oral hygiene habits. So bacteria accumulates on the carbohydrates in his oral cavity and starts to produce acid. This acid can start producing submicroscopic changes, very tiny spaces inside the enamel that can only be seen by a microscope, submicroscopic space. And so again, we said that enamel is the initial caries site affected with caries, unless, as we said, enamel, dentine, and cementum are exposed. As we mentioned before, caries is a dynamic disease or a dynamic thing that takes place. Periods of demineralization at first, so the salts are removed from the tooth by the action of acid, followed by other periods of remineralization, which is the position of minerals on the tooth surface after the pH gets back to normal or slightly alkaline. So minerals are then reprecipitated. These minerals are coming from both ways, either from the saliva and the minerals in the food that we eat, or from the inner surfaces of the teeth where the acid removed some of the minerals. On their way out of the tooth, they can be reprecipitated again in the areas of the teeth which were affected, and so this is remineralization or repair. It takes place all the time, so caries is a dynamic procedure, demineralization followed by remineralization all. Macroscopic appearance is how do we see these changes. First with our eyes, not under the microscope. At first, and we mentioned that in the clinical picture of dental caries, at first it appears as an opaque, chalky white spot, which we call the incipient caries. This thing, you can see it on, this spot can be seen on the smooth surface caries more. So it forms adjacent to the contact point. The dentist can see these opaque, chalky white lesions, and these are the things that if you see them and you advise the patient to change his oral hygiene habits and his feeding habits, caries can stop at this point, and it's one of the arrested caries we mentioned before. But if it continues, the dental caries continues to happen. So after having this opaque, chalky, white, hard area, it's hard at the beginning. It becomes little rough, in the surface becomes more rough, and it becomes softer than the normal tooth and starts attracting the pigments and the colors from the food and food and other pigments in the oral cavity, and so it gives the brownish color. In the pit and fissure caries, the same procedure takes place, but usually the fissure is too narrow, so you don't get to see the chalky white or the incipient caries thing. What you see is usually, or what you see first, is the brown spot before the white chalk. You don't see the white chalk. It happens, but you don't see it because the fissure is so narrow. So you see the brown spot, and again, if caries continues to happen and it spreads along the amylodentinal junction laterally on both sides, because the amylodentinal junction is less calcified, so it spreads there very quickly, and in this case it can cause secondary enamel caries, retrocaries from the amylodentinal junction upwards in the enamel, and it can spread to the dentine and causes undermining of the enamel. In this case, you can see a bluish color, which means the tooth is undermined or the enamel is undermined. So this is how we see it macroscopically. The brown, the white spot, the brownish discoloration, and the bluish if we have undermined enamel. In a ground section, and when we talk about enamel especially, we only see ground sections, which is the section that you prepare by grinding the tooth until it's so thin. You put it on a glass slide and you put a sticky material and a cover, and you start examining this lesion. In case of enamel, it's very hard to prepare a decalcified section because enamel is formed of a large amount of calcium salts. So if it is dipped in acid for a period to remove the salts, finally you'll see a dentine and cementum. You'll see the organic part in the dentine and cementum left behind. But for the enamel, what you'll see is just a space which was previously occupied by the enamel. So in a ground section, again, we'll divide caries in a ground section, and I told you how you do or you prepare this ground section. We'll see the smooth surface first and then the pit and fissure. In this smooth surface, we see a conical shape. Conical is like a triangle, okay? The apex is facing towards the amylodentinal junction or towards the pulp, and the base is to the outside. This is in case of smooth surface caries. And in this conical shape structure that we see, you have different lines or different zones. These zones are the result of demineralization followed by remineralization that takes place all the time. Pit and fissure caries, again, when we examine it under the microscope in a ground section, again we see the same triangular or cone shape, but in a different manner. The apex is outside, it's the opposite, and the base is towards the amylodentinal junction. But to tell you that because it follows the enamel rods caries procedure, or the acid and the things, the acid follows the and the destruction follows the enamel rods. But when you come to what happened exactly in this pit and fissure caries is that if you consider each side of the fissure as a smooth surface caries, so you have two triangles on both sides of the fissure, like two smooth surfaces caries. And when you combine the two triangles, you get this big triangle with the apex outside the tooth towards the saliva and the base towards the amylodentinal junction. And this is how it looks. Here, the brownish color is the enamel, the dark black color in the middle is the fissure. It has two sides, and you have two triangles on each side. Together, they make a large triangle with the base parallel to the thin black line at the bottom, which is the amylodentinal junction, and the apex is facing out. Okay, then we start to discuss the phases or how enamel caries takes place. when we talk about the phases in enamel caries, we usually start from the very outside, the very outer layer facing the saliva, getting to the inside of the enamel. Okay? So at first we have the phase of initiation, and this phase again is divided into 4 zones. Second, we have the phase of bacterial invasion, phase of destruction, and phase of secondary enamel caries. In the phase of initiation, it's just the action of acid on the enamel, producing the submicroscopic spaces we talked about before, and then these spaces becomes by time larger, allowing acid and bacteria to get deeper into the enamel. So it takes us to the second phase, which is bacterial invasion. So bacteria has access to get inside through the small cavities or small holes produced by the acid from the phase of initiation. Once the bacteria gets inside, more and more acid is produced, and so it starts destructing the whole structure of the enamel. A few or some other proteolytic bacteria also are present. They start eating up the small amount of organic material present in the enamel. And finally, it causes destruction of the enamel, and we reach the amylodentinal junction. When we reach the amylodentinal junction, caries spreads laterally with the acid and the bacteria, if it's there, laterally on both sides of the amylodentinal junction. And when this happens, secondary enamel caries takes place because it starts attacking the enamel from beneath upwards in the organic material present in the enamel, like the enamel tufts, for example, and it starts to undermine the outer layer of enamel, which is the hardest layer and which resists caries to the last moment, or keeps holding itself on the outer layer of the tooth until it is undermined. Then it can get fractured and a cavity is formed. And also, as a result of this spreading at the amylodentinal junction, bacteria and acid also starts to attack the dentine over a wide area, which is at the amylodentinal junction. So, phase of initiation, we will discuss each phase by itself. Phase of initiation, as you see in the picture, you have the cone-shaped structure with the different zones and lines inside, which means which are explained by remineralization and demineralization, which takes place all the time because of the dynamic procedure process in dental care. When we talk about the phase of initiation, we said it's again divided into 4 zones. Phases, we start from the outside inside, but when we talk about the zones, we start from the very deep inside of the caries lesion, going outside to the outer layer in contact with the saliva. So it's divided to the translucent zone, which is the very deepest zone, and then the dark zone, which is a thin zone on top of the translucent zone, and then we have the bulk of the lesion, which is the bulk of the body of the lesion, and then the very outer layer, which is the surface. Here is another diagrammatic picture for the zones in the first phase or phase of initiation. Translucent zone is the very deeper or the deepest zone. The dark zone on top, body of the lesion, which is the largest one, and then the surface zone, which is the most outer. To study caries in a tooth, we usually use 3 means of studying this caries. 3 ways we can study these changes. The first is a microradiograph, which is a very tiny radiograph that you put on an extracted tooth, and you take an X-ray picture, and then you can see the caries by looking at the different grades from radiolucent to radio-opaque, and you can tell that this part of the dentine of the enamel is less calcified than the other one, so it looks darker in the X-ray. The outer is highly calcified, and that's why it looks more radio-opaque. So the more the calcium salts, the more radio opacity. The less the calcium salts, it looks darker, and it's all relative. So you just compare the disease part to the normal part to know how much is there any loss of minerals or not in this area. So it's a microradiograph. Second means is by the polarized light microscope, which you can see it in this picture. And finally, our transmitted light microscope, where we prepare the ground section and, as we said, put it on a glass slide, put a cover with a sticky material, and start to examine it under. Why the translucent zone looked translucent? I forgot to tell you this on the other slide. It looked translucent because when we put the sticky material with the cover, it filled up the small minute spaces between the enamel prisms. And this material has the same refractory index as the enamel itself, and so under the microscope it looked like translucent or like normal enamel. When we get to the second zone, the dark zone is the zone superficial, looking more to the outside, to the saliva interface, superficial to the translucent zone. Here we still have more pores. So in the translucent zone, we had some pores here, 1%. Here it's from 2 to 4% by volume. More demineralization, of course, and in an X-ray microradiograph, this zone will look more radiolucent than the previous one. But why under the microscope it looked like a dark zone? It looked like a dark zone because after the salts has been removed from this layer, and in the period of remineralization, the repair, some salts from the translucent zone, which is the deeper zone, has been precipitated again when the pH went back to normal or a little bit alkaline. Some minerals were reprecipitated on this zone. And when they were reprecipitated, some of the enamel prisms increased in size, the others did not. Some of the spaces were very tiny, the spaces between the other spaces were larger, and so when we put the sticky material, it did not fill up all the spaces. It filled some of the spaces, and the other spaces were filled with air. They were very tiny that the sticky material could not fill them. And so that's why under the microscope they looked like black. So we'll read this to make it clear, to explain it again. In this zone, after remineralization, two differently sized pores coexist in this dark zone. Some were filled with the minerals from the deeper zone during the remineralization, and some were not. So some are smaller than those of the translucent zone, and some are larger, suggesting that remineralization has occurred due to the precipitation of minerals lost from the translucent zone. On their way out, they were reprecipitated in this zone. And so they had two different sizes of spaces. Some were filled with the sticky material, some were not, and so air was trapped, and that's why it looked dark. This dark zone is very narrow in rapidly advancing lesions, like in rampant caries. But in slowly happening caries, it is wider and it is well seen. But in the rapidly advancing lesions, like in the rampant caries, this dark zone is very narrow because there is no enough time for reprecipitation and repair place. Body of the lesion, again, it is the largest area, it is the bulk of the lesion, and it is full of debris. It still has loss of minerals. In the center, the minerals are lost even more than the outer sides of this lesion, and it attracts a lot of pigments and debris from the oral cavity, and that's why it gives the brown spot of the lesion. It gives the color of this caries lesion. So this zone is more superficial to the dark zone, or to the translucent zone as well, it is seen clinically as a brown spot. And as we said, the staining may be attributed to the exogenous pigments from food, tobacco, and bacteria. Here in this zone, there is even more loss of minerals from 5 to 25, usually 5 at the periphery and 25% in the center. And there is, again, reprecipitation, but it has a lot of debris and it is less calcified than the rest of the lesion. And in an X-ray, it will even look darker than the dark zone. This zone is broader in progressing caries and narrow or narrower in arrested caries. Finally, we get to the surface zone. The surface zone is the very outer layer in contact with the saliva and the outer environment. This zone, we still have pores, but again, it goes up to 1% only, so there is less mineral lost here than the other, than the body of the lesion or the dark zone. The reason for that is that although it is the first lesion affected or attacked by the acid and bacteria, but it is always subjected to repair from the outer side. Minerals are precipitated from the oral cavity and the saliva, and some are precipitated from the body of the lesion or the third zone from the other side. So it gets salts from both sides, from the oral cavity, from the saliva, and from the inner zones. And so this zone is the hardest, and in an X-ray, it's more radio opaque than the other zones. And since it is hard and has a lot of minerals in it, it remains intact for so long. Although there might be cavitation and caries underneath, this zone resists this caries and remains intact for so long until we get the secondary enamel caries at the amelodentinal junction, and then it becomes undermined, and we see it with it looks clinically as a bluish color when it's undermined, and then this zone can easily fracture, and once it's fractured, then you get what we call a cavity, and you have a wide area for bacteria and acid to attack the tooth more. So we just read the slide. We mentioned all this before. It has the highest mineral content. There is active reprecipitation of minerals from both sides, from the plaque saliva side and from the minerals dissolved in the deeper layers. And it remains intact for so long. Once this layer is undermined and it's fractured, then cavitation takes place, allowing bacteria to get inside the tooth. Here we have two pictures. I'm sorry because like the laser printer, the laser thing, and even the mouse are not showing when we replay the video. I don't see them, so I'll just tell you and you try to follow me. First picture on the left, we can see the conical shape thing, structure caries. It is, the base is to the outside and the apex to the inside, and you can see the different shades, the translucent, the dark from the inside to the outside. You have the translucent zone, the dark zone, the body, and the outer layer. In the pit and fissure, you have the same thing, but the apex is outside to the saliva side, and the base is at the amelodentinal junction, and you have the different shades and grades. If we look and consider each side of the fissure as a smooth surface, then we have two triangles on both sides. Together they give this big triangle. Second phase, from the outside inside, we had the phase of initiation with its 4 zones, and then we get to the second phase, which is the phase of bacterial invasion. Once we have more pores in a phase of initiation, it becomes more larger and larger with the action of the acid, allowing bacteria to get inside. Once bacteria starts to get inside, it starts to produce more acid, destruct more enamel, until finally some proteolytic bacteria as well are there to remove the remnants of the organic part of the enamel. Phase of destruction. In this phase, as we said, there are again loss of minerals, and finally, as we said, proteolytic enzymes are released by bacteria to digest the organic matter remaining. Finally, phase 4, which is the phase of secondary enamel caries. As you took this before when we talked about the classification of dental caries. So in this phase, the bacteria spreads more quickly and faster at the amylodentinal junction. The reason for that is that the amylodentinal junction is less calcified, contains more organic substance, and so it allows the bacteria and the acid to spread laterally. When they spread laterally, they attack the enamel from below, so we get what we call the secondary enamel caries. Okay, this secondary enamel caries, with the spread of the caries at the amylodentinal junction, will make this tooth or the enamel in this part undermined, and so it can easily fracture and break, forming a cavity. So, last thing to say is, when secondary enamel caries occur, or when the bacteria spreads and the acid at the amylodentinal junction, what do we get? We get three things. Three things happen. First of all, this enamel, or the enamel we are talking about, loses its support from the dentine side, and then it's weakened and it can fracture and cause a cavity. Cavitation starts. Second thing is that secondary enamel caries takes place and the enamel is attacked from below. Third thing is that when the bacteria spreads at the amylodentinal junction, it starts attacking the dentine on the other side over a wide area. So this picture shows Pitton-Fisher caries with cavity in the enamel, and the amylodentinal junction is below the cavity. You can see it. And at this amylodentinal junction, you can see separation between the dentine and enamel. There is a space, and you can see the dentine attacked over a wide area, showing a triangular shape in an opposite direction because it has been attacked over a wide area. Here on the left first, here you have caries but no cavitation, just discoloration and loss of minerals, and maybe bacteria had access through the large pores, or maybe just the acid. And then you see the amylodentinal junction below, and the shape of the caries lesion is a triangular shape, and you can see some changes in the dentine below this caries lesion, and you can see that the dentine has been attacked over a wide area. In the picture on the right, you see a small hole or a small cavity that you can see in the oral cavity with your eye when you examine this patient, but below there is fracture and there is a large cavity in enamel, undermined at the amylodentinal junction, and the dentine is attacked over a wide area. Again, here in one part, the left part, you just have caries in enamel with some changes in the dentine and at the amylodentinal junction, but no cavitation. On the right side of the same tooth, you can see cavitation, separation at the amylodentinal junction between the enamel and the dentine, and an actual cavity in the enamel, fracture of the undermined enamel, and a lesion in the dentine.